First of all, we do assess all of our patients who are here for their hemorrhage risk. You will get a task in the electronic medical record every shift, and you need to complete the power form that's attached to that task. We do want you to take appropriate actions if your patient is considered high risk for hemorrhage by making sure you've notified the physician and checked to make sure that she does have a tube of blood on hold. If we're in a downtime, you need to complete the paper form and place that in the chart. So this is an example of what our post-delivery hemorrhage risk factor paper form looks like. And I know it's small, but you can see that depending on how many things you check, the patient would fall either into the low, medium, or high categories on the left, and then your interventions are different depending on which category they're in. We also have postpartum hemorrhage kits in our Pyxis, so these are medication kits to use in the event of an emergency. It's always going to be in the Pyxis that has the refrigerator attached to it, and the contents of it, well, cubby opens separately, but you would take 2 vials of Pitocin, 1 premixed bag of Pitocin, 5 tablets of Cytotec, 2 vials of Methergine, and 2 vials of Hemabate, and that way you don't have to run back and forth between the Pyxis and the patient's room. So how do I get it out of the Pyxis? You do need to be logged into the Pyxis that has the refrigerator on it, and then you're going to select all patients and pick the patient who's having the emergency. You want to then select Override at the bottom, and then look for System Kits. Once you've picked System Kits, it'll allow you to select the hemorrhage kit, and then the drawers will open one at a time for you to get the medications. Let's talk about the medications that we would be using. We could be using Pitocin, Methergine, Hemabate, Cytotec, or a combination of all of them. Pitocin, if you're giving it IV, at our facility we generally have 30 units and 500 milliliters pre-mixed, and that's going to work pretty quickly as soon as you start it, within about a minute. It'll last about 30 minutes from the time you start it. We don't give it by IV bolus or IV direct push. And ideally, you don't give it by more than 1 route simultaneously. If your patient doesn't have IV access and you're giving it IM, a normal dose is 10 to 20 units, and that will take effect within about 3 to 7 minutes and last for an hour. You do want to make sure you're monitoring this patient's I&O and you're not overloading her with fluids. She is going to experience uterine cramping, hopefully not any seizures or coma from water intoxication. You do want to make sure that you're aware whether she's had any IV or inhalation anesthetic agents, and vasoconstrictors can increase her risk of hypertension if she also is on those. Pitocin's not compatible with Compazine, Levophed, and Coumadin. Let's talk about Methergine for a minute. So if you give Methergine IM, the dose is 0.2 milligrams every 2 to 4 hours until you've given a max of 5 doses. It also works pretty quickly, within 2 to 5 minutes, but it will peak in 12 to 15 minutes. You can give it IV, but in a life-threatening emergency only, and the dosage is the same, 0.2 milligrams, but you're going to give it slow IV push over at least a minute while you're monitoring the patient's uterine contractions. And you can dilute that dose with 5 milliliters of normal saline. It is going to have an immediate onset and will last to about 45 minutes. After usually either of these regimens, the physicians do prefer to switch the patients to PO Methergine once they're stabilized, and that dose is also 0.2 milligrams, but it's going to be every 4 to 6 hours. So who wouldn't I give Methergine to? I would not give Methergine to a patient who had hypertension, and I would want to make sure that I had informed the physician of that, or if I received an order for Methergine. I do want to take into consideration that the patient with asthma or cardiac disease may also be at increased risk for side effects or complications, and let the physician know that. So that means it's important for that primary nurse to stay at the bedside. Never want to give Methergine before the delivery of the baby or the placenta. And with any other drug that you're giving during a postpartum hemorrhage, you want to make sure you're monitoring the patient's blood pressure, pulse, what her uterus is doing, and the amount of vaginal bleeding she's having. Now, for Methergine specifically, hypocalcemia may decrease her response to it, and so that would be important to know in a patient who's on max sulfate, because as her max sulfate levels rise, her serum calcium levels may decrease. Side effects of Methergine: she may have dizziness, headache, she could have some transient hypertension or palpitations, she may have some nausea and vomiting, she's definitely going to have some cramping. Methergine is incompatible with digoxin, some antibiotics, heparin, Coumadin, and epinephrine, and you want to use it with caution in someone who's had regional anesthetics or has IV Oxytocin going. So Hemabate is given deep IM only, and the dose is 250 micrograms. And it's usually used for uterine atony that's not responded to conventional management. You can repeat the dose at 15 to 90-minute intervals for a max total of 2 milligrams. It will onset in 15 minutes and will peak in 2 hours, so it's got a little bit longer onset. It's not unusual for them to get nausea, vomiting, diarrhea, or a headache, They can also have fever, chills, tachycardia, or hypertension. And you really want to consider not using it in a patient with asthma if she's got severe renal, hepatic, or cardiac disease as well. Cytotec is the next drug, and it can be given either orally or rectally. The oral dose is generally 400 micrograms, but the range for the appropriate dose is anywhere from 200 to 800. Rectally, generally, we're giving 1,000 micrograms, and that's why I told you to pull out 5 tablets, because it comes in 200 microgram tablets. These patients generally will get nausea, vomiting, diarrhea, and a headache. You don't want to give it in a patient who has an allergy to prostaglandins. Each unit also has a postpartum hemorrhage cart that should be brought to that patient's room. The cart only has supplies on it. There are no medications, but it has all the supplies that you should need to manage a hemorrhage, so you only need to grab that cart. Now, where are they located? It depends on what floor you're on. And since most of these are supply or storage rooms, the person who's going to retrieve it would need a code to get in, so make sure that you're sending someone from your unit to get it. There is such a thing as our postpartum hemorrhage tackle box. We have one tackle box that's located on 4-tower mom-baby unit. It also contains the basic supplies needed to manage a hemorrhage, and it's to be used for a hemorrhage in a postpartum mommy who's visiting her baby in the NICU. So a nurse from 4-tower would take the tackle box to the NICU by stairs, while another nurse would bring the postpartum hemorrhage cart by the elevator. If you have a patient experiencing a bad postpartum hemorrhage, please call an RRT-OB, or a rapid response to OB team. It's going to bring more people to you, and you can do this by dialing 66 to reach the operator. Please don't forget to tell her the code RRT-OB, what unit you're on, and what hospital you're in. So who all will that bring? Well, the primary nurse is already at the bedside, and she may be the one who's calling it. But it'll also get you the AOD, your charge nurse if she's not already in there, the PACU charge nurse, a hospitalist, an anesthesiologist, a cardiopulmonary therapist, a social worker or chaplain, and the labor and delivery charge nurse. So what do I do if my patient's hemorrhaging? Well, the first thing to do is recognize it and call for help, and then immediately begin fundal massage. If your patient has Pitocin running in her IV, you can turn the rate up to 333 for about 15 minutes. By that time, you should have help in the room and a physician at the bedside who can tell you whether or not we're going to titrate it down or stop the IV Pitocin based on how the patient's responding. If your patient is not maintaining consciousness or her pulse oximeter is down, go ahead and apply an oxygen mask to the patient and give oxygen at 10 to 15 liters. Vital signs should be obtained a minimum of every 15 minutes, but if she's having a significant hemorrhage, get them every 5. Make sure you've notified a physician. Send a second nurse to retrieve that postpartum hemorrhage cart and another nurse to retrieve that postpartum hemorrhage med kit out of the Pyxis. Have someone start a second IV line. Check the patient's bladder to make sure it's not full, and if you're not sure or if there is any bladder fullness, go ahead and insert a Foley catheter. And give any medications as ordered by the physician, and make sure you chart all the interventions you did. The lab tubes in our postpartum hemorrhage cart, if you need to send a type-in screen, get a pink tube. A CBC would be a purple top. A CMP is a red top. And a PTT or a fibrinogen is a blue top. Now, here we measure quantified blood losses, or QBLs, so we would want to weigh all bloody items on the baby scale, and then subtract appropriate dry weights for the number of items weighed. 1 gram of blood loss equals 1 ml of blood loss. So here's a chart of our dry weight measurements. This is found in a binder on top of every postpartum hemorrhage cart. So for example, if the patient had saturated 3 large blue chucks, 1 green cloth chucks, and let's say 2 pink peri pads. You're going to put all of that on the baby scale, get your total weight, and then subtract the dry weight of each thing. So I think I said 3 large blue chucks, so we would subtract 150. Plus we would subtract from the green cloth chucks of 374. Plus we would subtract the 2 peri pads, the pink peri pads, which would be 40. There is a calculator in the top drawer of each postpartum hemorrhage cart, which can help you with this math. Our documentation, we want to make sure we're completing our hemorrhage risk assessments, which we talked about earlier, and definitely continue to do them even if it's downtime. For her blood loss, you want to put it under I&O, and make sure that you add a comment for the method used to quantify blood loss. On the postpartum floors, we weigh things. Down in labor and delivery, they do have graduated drapes which measure things. At the end of the immediate postpartum period and in the delivery record, that should be annotated blood loss in each of those time frames. And if you have any suspicion of increased bleeding, you want to begin weighing blood-soaked items right away so we can get get a good start on the hemorrhage and not wait until the patient has lost a significant amount of blood. You want to document your hemorrhage stage in the OB nursing notes at the end of the recovery or event. And you want to document your interventions. For the postpartum floors, we would go to OB ongoing assessment band in iView under postpartum view section and document, yes, it was a hemorrhage, and then another section will pop up and allow you to select what interventions you did. Now these interventions are quick checks, you can just check them, but that's just kind of a way to bookmark what time you did things. You will have to, for example, if you started a second IV, you will have to go back in and do the appropriate documentation of what gauge catheter you used, what length catheter, and where the site was for that IV. If you're giving a blood transfusion, again, that's under iView in the blood transfusion band, and you want to be sure to complete all required documentation, which includes scanning the bag, making sure you have a witness, the start and stop times, any reaction, and was the ordered volume given, as well as the vital signs and consent. And make sure that you've also documented the volume that was actually infused, and that will flow to iView. Make sure you're reporting the blood loss to the oncoming nurse for a stage 1 hemorrhage or greater, and you would want to be telling her the QB up. Now, if you want to make sure that the story is complete, you can go to ad hoc in your OB folder and get an OB narrative note, and this will allow you to kind of document a chronological note to tell the whole story of what happened, when interventions were done, but it doesn't eliminate the need to make sure that her vital signs and her EBL get into IV. We do debrief after every stage 1 hemorrhage or greater, and debriefing is nothing more than just reviewing an event or scenario that was unexpected, and it allows the entire team to discuss things like what happened, what did we do well, what could have gone better, so that we can continue to improve our care. We do have ground rules in every debriefing. We're not allowed to blame, accuse, or finger point anyone. We don't interrupt someone who's currently speaking. And you want to keep your comments brief and event specific. And then anything discussed in the debriefing is considered confidential and needs to stay in the debriefing. If you forgot to say something during the debriefing and you realize it afterwards, please bring it to your nurse manager or charge nurse so that could get added to the debriefing form. But debriefings are not supposed to be discussed outside of the debriefing with anyone else, and you can't discuss the event with anyone else. So the goal of our debriefing is to review the unexpected event, hopefully in a timely manner. We hope to hold those within 30 minutes of the case, if that's possible, and get as many people from the specific care team that participated in the event at the debriefing as possible. Ideally, a debriefing is held prior to the completion of all documentation, so that we make sure we have the accurate and consistent story of what actually happened for the patient and that we've gotten everybody's point of view. Any issues raised in the debriefing should be reported to the charge nurse or AOD, and they should go then to the manager so we can follow up. And there is a form that I'm going to show you in a minute that you can document the recommendations on. That is the debriefing form. And once the debriefing form is completed, it should go in the manager's mailbox unless the AOD takes it. And a debriefing does not replace an event report if that should need to be filed. This is a look at our system-wide hemorrhage team debriefing form. You can see most of it is check boxes, but there are places for you to write in things that are opportunities for improvement. If you have any questions, please see your educator prior to attending a postpartum simulation drill. And thank you for paying attention, and hope you have a great day.